All right, good afternoon, everyone. Hope you had a good week. Tomorrow, you'll be getting one exam on quiz number 17, lymphomas and non-Hodgkin's lymphoma. And then at the end of this lecture, I'll do a review on that one quiz. And then the following next week, on November 11, you'll be getting a quiz, of course, on today's lecture, which is the myeloproliferative disorders. But in addition, you'll be getting your exam 4 on lectures 14 to 18. Okay, and then after this lecture, I'll be doing a review. This is going to be multiple choice on the exam 4, multiple choice and matching. Okay, few more questions on the multiple choice, and then of course you'll have matching. In addition to your exam 4 next week, you're going to have another. I know I told you that you're not going to get a comprehensive exam in hematology, but you are going to get somewhat of a comprehensive exam, but it's going to be matching. And I'm going to give you the reviewer, and I'll go over the reviewer after this lecture. Since it's only one lecture today, I'll go over the reviewer. You're going to get the reviewer, and what I want you to do is memorize the terms on the reviewer. They're broken out by sections, and all you have to do is associate each term with each disease, with each phrase in each section. This shouldn't be too hard, because I'm actually giving you the answer key. The thing is, I'm going to mix everything up, and you're going to have to put everything back together. All right, so it's going to be a lot of points. I think it's going to be 176 points just for that matching exam alone. So there really shouldn't be any reason, because I'm giving you the reviewer today in preparation for next week's mega matching exam. All right. And then, of course, I'll go over the review for the quiz tomorrow, and then I'll give you the review for your exam for also at the end of this lecture. So at this point, are there any questions? Okay. Before I get started on myeloproliferative disorders, there's a couple points that I want to go over. I meant to include them in my lecture, and that's on non-Hodgkin's lymphoma. I know that the reason for there isn't any really known cause for non-Hodgkin's lymphoma, but you've heard on the televisions, you've seen the Roundup commercial. That's been a culprit in what causes non-Hodgkin's lymphoma. So kind of a cause for the non-Hodgkin's lymphoma, I'm going to say Roundup weed killer. I'm sure you've heard of it on the television. So that's been implicated in a lot of non-Hodgkin's lymphoma. So that information I'm going to hold you liable for. It's new information, but I just want to make sure you get it. Also, too, in the acute leukemias, there's one point of information I wanted to make sure that you have, that for M5, the acute monoblastic monocytic leukemia, one of the symptoms of M5 is gingival hypertrophy. And what gingival hypertrophy is, it's bleeding gums, okay? And you get bleeding gums because it's infiltration of the monocytes and monoblasts in the gums. So that's kind of characteristic. It's a characteristic symptom of M5. So gingival hypertrophy is one of the big symptoms, and I've included that in my lecture. So make sure you make note of that, or I can send you the slides separately, and so it's part of your notes. So those two important pieces of information I neglected to tell you: the gingival hypertrophy for sure on this M5, and Roundup weed killer. Okay. So today, I'm going to talk about the myeloproliferative disorders. So you all know what this is, right? Anybody, just shout it out. What do you see here? Anybody, please? Doesn't that,
Myeloblasts?
what was that?
Myeloblasts?
No, no, it's not a myeloblast. Doesn't this look like deviled egg?
Mm.
Doesn't this look like deviled egg? I mean, if you cut a hard-boiled egg in half and the yolk is off to the side like that, doesn't it look like deviled egg? And what was my trick on deviled egg? What kind of cell is this? It's a type of lymphocyte.
Is it atypical?
Nope. This is a plasma cell. Okay. This is a plasma cell. No other cells look like this. Okay. They're oval. It has the Golgi, has an eccentric nucleus. It has an eccentric nucleus. If I was teaching the laboratory, I'm not quite sure what Xavier's doing as far as cell identification, but I'd be going over this and you'd be getting cell identification in the laboratory. But this, I went over this, is you have an eccentric nucleus, it's almost perfectly round. Eccentric means it's off to the side. You see a Golgi here, and of course it's a lymphocyte because of the bluish cytoplasm, okay? So I make the comparison that this is like a deviled egg. I mean, boil some eggs tonight, cut it in half, and I swear it's gonna look like this. Okay, so that's why I call this a deviled egg. All right, and that's part of the matching tricks. And with regards to the tricks that I told you, it's like I told you the trick for M5 mono. So many of you got it, but a third of you got it wrong. And I give you these tricks and shortcuts to help you guys learn this stuff. But if you're not, and it was mentioned in the lecture, so either you're not listening to the lectures that I'm recording for you, you're not making good use of the lectures, the recordings, or you're not paying attention to the tricks. These tricks, when you take your board exam, you're going to need to know the shortcuts and easy ways to memorize things. When I teach microbiology next semester, I'm going to be giving you a lot of this, and you're going to have to rely on them. And then when you take your board exam and study for them, you're going to need to say, what was it again? What was that deviled egg thing? I know this looks like a deviled egg. I don't even know what it is. And it's like, you guys were giving me blank stares. Right away, this should have been plasma cell. Okay. So myeloproliferative disorders. It's not only plasma cell, but that's just part of this lecture. Okay, CMPDs are chronic myeloproliferative disorders. Are a group of heterogeneous diseases that originate from the clonal expansion of the hematopoietic pluripotential system. So basically, that's a lot of words that you may or may not understand, but it has to do with embryonic development. So in the embryonic development, hopefully things go well and you get 5 fingers, you get your blue eyes, blonde hair, etc. You got your nerve cells, your cardiac tissue, etc. Everything goes well. But when things don't go well, then you can develop some things like myeloproliferative disorders. These disorders involve more than one cell line. That's the important thing about this. And I talked about multi-lineage disorders. When you have a multi-lineage disorder, that's actually not good. Multi-lineage meaning if it has involved the red blood cell line, the myeloid or the white blood cell line, or the platelets. So a lot, these disorders include the 3 cell lines. Pluripotency is the ability of the human embryonic system to differentiate or become almost any cell in the body. So that's where the defect takes place, is in the differentiation part of embryonic development. Overproduction, myeloproliferative disorders is overproduction of one or more of the formed elements in the blood. And the 3 formed elements in blood are red blood cells, white blood cells, and platelets. So there's a problem in the development of one of the formed elements, and usually it's overproduction, like overproduction of platelets, overproduction of red blood cells, and overproduction of myeloid or the granulocytic cells, the cell lines. So this is the development in vivo fertilized cells. You get division taking place. Division further takes place into a blastocyst. And then this is a pluripotent cell. And after here, this is where differentiation takes place. Differentiation, as you recall, is when you start getting defined organs. Like here, you got nerve cells, or you got cardiac muscle, or you got red blood cells, or you get the 5 fingers or the 10 fingers, blonde hair, blue eyes. At this point, this is the hub. This is the starting point where you get all your differentiation or your defined organs, defined parts of your body start developing. So you get cell division here, you get further cell division, and then finally you get the embryo. Okay. So chronic myeloproliferative disorders encompass 4 clinical entities, and you need to know this. The chronic myelogenous leukemia for the white blood cells, polycythemia vera for the red blood cells, essential thrombocythemia, which is ET, which is the platelets, and idiopathic myelofibrosis. So CML is the leukemoid or involves the white blood cells. Polycythemia is the red blood cells. Essential thrombocythemia. Now, thrombocythemia, it means excess or overproduction of platelets. Now, you may have seen the term thrombocytosis. That's the same thing. So if you see thrombocytosis or thrombocythemia, it just means an excessive amount of platelets. So essential thrombocythemia, a lot of platelets. And idiopathic myelofibrosis. So myelofibrosis, meaning that there's a lot of fibrin, or it refers to the bone marrow. The bone marrow is fibrotic. So in the bone marrow, when they do a bone marrow aspiration to go into to get some bone marrow material, so the pathologist wants to know what's going on with any kind of hematopoiesis or development of either myeloid or erythroid cell line, he'll do a bone marrow tap. And in myelofibrosis, he'll end up getting a dry tap because the bone marrow is so fibrotic. It's all fibrin, it's dry. So he won't be getting any kind of marrow material. So when that happens, because the bone marrow has been infiltrated with cancer production cells, you're going to get extramedullary hematopoiesis because, it's not happening in the bone marrow because now it's been infiltrated with fibrin. So that's one of the things that causes extramedullary hematopoiesis. But that's one of the 4 entities of chronic myeloproliferative disorders. Just remember, it's like the 3 different cell lines, the formed elements: the white blood cells, the red blood cells, platelets, and the marrow is fibrotic because of the amount of fibrin in the marrow. So CML is excessive production of granulocytes, like I said. PV, which is polycythemia vera, is the overproduction of erythrocytes, RBCs. And ET, essential thrombocytosis or thrombocythemia, is the overproduction of platelets. So it's all overproduction. And idiopathic myelofibrosis is a prominence of marrow fibrosis or fibrin. And that's what prompts, like I said, extramedullary hematopoiesis. Now, you got to have hematopoiesis to survive. So what causes it to be extramedullary is the amount of fibrin that's been infiltrated into the bone marrow. So now you have extramedullary hematopoiesis, and it takes place in the liver and the spleen. So hopefully that makes sense. So you got overproduction of the 3 cell lines, and then in the bone marrow, your bone marrow is fibrotic. Okay. One characteristic of chronic myeloproliferative disorder is splenomegaly, enlargement of the spleen. It's found in more than half of the patients, 40 to 99% of the patients. There are other classifications that the World Health Organization has added on to the myeloproliferative disorders, but I'm not going to focus on them. But they include neutrophilic leukemia, chronic eosinophilic leukemia, hypereosinophilic syndrome, and unclassifiable myeloproliferative disorders. So I'm not going to focus on those. Just these four entities are the ones I want you to know. Okay, primary polycythemia as opposed to secondary polycythemia. So in primary polycythemia, it involves the erythroid cells, okay? You got uncontrolled proliferation of erythroid cells or RBCs. Remember, overproduction. It's uncontrolled proliferation of RBCs or erythroid cells due to an abnormality of the bone marrow, okay? But in addition, you've got proliferation of granulocytic and megakaryocytic cells. So granulocytic is myeloid, correct? So granulocytic is myeloid, and megakaryocytic means that it involves platelets. So here in primary polycythemia, it involves 3 cell lines. The primary involves 3 cell lines, RBCs, myeloid or granulocytic, or platelets. So primary involves the 3, okay? As opposed to secondary. Secondary polycythemia will only involve erythrocytes, So primary is 3, granulocytes, platelets, and red blood cells. And secondary is red blood cells or erythrocytes only. So in secondary polycythemia, we have overproduction of red blood cells, correct? And that's because we have increased production of erythropoietin. Remember what erythropoietin is, right? Erythropoietin is made in the kidneys, and erythropoietin stimulates the production of red blood cells. It's something that they give, it's a hormone actually that they give dialysis patients, because every time a patient has dialysis, the return of the fluid that they take out to be filtered and have the impurities taken out of the blood, and it's returned. A lot of the return is does not include some red blood cells that were taken out due to filtration. So in order to replace those red blood cells, they need to give erythropoietin, because after dialysis, then the patients are usually tired because they have fewer red blood cells than they had coming in. So they need to be given erythropoietin. I don't know if you knew that. So it's either, it's called epogen or EPO or erythropoietin. So you need to have, because of the erythropoietin, we have increased production of red blood cells, okay? Okay, polycythemia vera is a chronic disease. It's a chronic disease with insidious onset. Remember what insidious onset is? You don't know you have it until you go to the doctor's office, and then he'll run some blood tests, and then he'll find out, wow, you got a lot of red blood cells, or you got a high platelet count, or you have a lot of platelets, high platelets, white blood cells, and platelets, white blood cells, and what's the third cell? What am I missing? Platelets, white blood cells, and red blood cells. Okay, so one thing about having an excess amount of red blood cells is that your blood becomes viscous. Viscous meaning that it's thick, okay? It's thick. Hyperviscosity and elevated platelets. That thickness or the hyperviscosity causes problems with the patient. So the symptoms include headache, epistaxis. Epistaxis means bloody nose, nosebleed. Forgot to write that there. But epistaxis is nosebleed. Ischemic or hemorrhagic stroke, because you don't want this thick blood going through your brain, so you're at risk for getting a stroke. Angina, chest pains, myocardial infarction, and claudication. And claudication is pain caused by too little blood flow during exercise. The too little blood flow, again, is one of the causes of, or one of the reasons that is one of the things you get from the hyperviscosity. So you have thick blood, you have RBCs, an excess amount of RBCs. So your blood is thicker, it's more viscous, causing those symptoms: the headache, the nosebleed, the stroke, the angina, the MI, and the claudication during exercise. So the laboratory findings, obviously you'll see elevated RBC count, moderate thrombocytosis in 60% of the cases, and leukocytosis in 40%. You got elevated overproduction, like I said, up to 3 cell lines. Hematocrit is 58% and 52 in men and 52% in women. Important to separate hemoconcentration from true increase in red cell mass. Now, hemoconcentration is false elevation. Hemoconcentration is false elevation due to dehydration. So when you're dehydrated, it appears that your RBC count or your H&H is elevated, but that's only because you're dehydrated. You can cure that or fix that by rehydrating yourself. So you have to make sure the patient's adequately hydrated, as opposed to this disorder where you have a true increase in red cell mass. Here you have a true increase in red cell mass. MCV is decreased, so the red blood cells are small. Normal hematocrit with profound microcytosis. So you can have microcytosis, increased number of small red blood cells, and have a normal hematocrit. And that's virtually diagnostic of polycythemia vera. Okay, MCV is small, but you have a ton of small red blood cells. That's why you have a normal crit. Okay, and this is the microcytosis secondary to gastrointestinal blood loss. So secondary to probably a GI bleed. The treatment is to provide symptomatic relief. Obviously, you heard the symptoms. You got headache, you got nosebleed, you got MI, you got chest pains, you could get a stroke, or you can get pain upon exercising. So provide symptomatic relief. Minimize long-term complications, avoid increasing the risk of leukemic transformation. So the most common treatment in treating this polycythemia vera, the excess or overproduction of red blood cells, is therapeutic phlebotomy. Okay, have you guys ever heard of therapeutic phlebotomy? Okay, that's where if you have a red count that's incredibly high, you need to get rid of these red blood cells. So what that is you'll be sent to the donor center. So you'll be sent to the donor center to donate a unit of blood. Now to donate a unit of blood because you have to decrease the amount of red blood cells in your blood. It's therapeutic. The phlebotomy, or the removal of blood from your body, is therapeutic. So that's your therapy. That's your treatment. You donate I shouldn't say you donate it, because the unit that you're giving up or that's being removed from your body cannot be used for blood bank or for community reasons. Okay, so it can't go into the pool to be typed in cross-match so it can be given to another patient. Keep in mind you've got some kind of disorder, so it's treated as taking blood out of a sick patient. So the blood is not really healthy blood. Actually, like for example, overproduction of platelets, overproduction of white blood cells, those white blood cells are not functioning properly, or the increased platelets, those platelets are not functioning properly. So the red blood cells, even though you have overproduction because it's a myeloproliferative disorders, you have to do therapeutic phlebotomy to remove the red blood cells from the body. You guys know what they used to do before they did the therapeutic phlebotomy to remove blood?
Was it leeches?
Right, they did the leeches. Okay, so they give the patient leeches. They let the leeches do what they're supposed to do, remove the blood, and that's supposed to cure the patient of this disorder. So for polycythemia, the therapy is the treatment is therapeutic phlebotomy. Okay, platelets. Now you have essential thrombocythemia or essential thrombocytosis. Remember, thrombocythemia and thrombocytosis mean the same thing. It's overproduction of platelets. So myeloproliferative disorder characterized by marked thrombocytosis, increased platelets. These platelets do not function normally. Okay, these are sick platelets. They don't function in clotting your blood correctly, and therefore the patient has an increased risk of thrombocytosis, thrombosis, and hemorrhage. Okay, because you need platelets to stop yourself from bleeding. One of the signs of having improperly functioning platelets is that you'll bleed too much. You'll bleed and you won't stop bleeding, or you have bruising. Okay, those are the signs. When you have it takes you a long time for you to stop bleeding, that's a problem with your platelets. And as when we get into coagulation, I'll be talking about the bleeding time tests. And also too, even though you have overproduction, you would think that you have enough platelets to stop you from having coagulation disorders. Again, those platelets are not functioning, are abnormal platelets, and they don't function the way they're supposed to. Okay, so essential thrombocythemia can be seen in CML, chronic myelogenous leukemia, polycythemia vera, and idiopathic myelofibrosis. Platelet count is high. With a normal count of 140, 440, platelet count is more than 600, okay? More than 600, and is often greater than 1,000,000, okay? Or 1,000 times 10 to the 9th. In the bone marrow, you have megakaryocytic hyperplasia. In the bone marrow, the main cell that produces the platelets is called the megakaryocyte. It's called the megakaryocyte. So you got megakaryocytic hyperplasia. So the megakaryocyte is just producing platelets, and the megakaryocyte, as I'll show you later on in the lecture, is the largest cell. Even though the platelets is the smallest formed element, the megakaryocyte is the largest cell in the bone marrow. I'll show that to you. Absence of the Philadelphia chromosome. Remember, for the Philadelphia chromosome, I want you to know and memorize that the Philadelphia chromosome is only significant for CML. Okay, Philadelphia chromosome is significant for diagnosing or identifying chronic myelogenous leukemia. Absence of the Philadelphia chromosome and myelofibrosis and hemoglobin no higher than 13. Okay, so the patient can be anemic, but the marrow can also be fibrotic. That's part of the 4 conditions of myeloproliferative disorders. Remember, the idiopathic myelofibrosis. You have a fibrotic marrow. The incidence of thrombocythemia is in the population is 2.5 per 100,000 in the population. It's the most frequent of the myeloproliferative disorders, with about 6,000 people diagnosed annually in the United States. Elevated platelet count. We see elevated platelet counts a little bit more than occasional. A little bit more than occasional. So it's not rare, it's not occasional, it's a little bit more than occasional. It's not common, in other words, okay? And the median age is 60 years of age, or more common in women than men, at a ratio of 1 to 6. It's more common in women. Okay, so this you would think is a lymphocyte. It looks like a lymphocyte. It also kind of looks like a lymphocyte, but guess what? It's not a lymphocyte. Okay, if you look at the nucleus, it almost looks like a small blast, but and it looks almost like a hairy cell leukemia. You have to be, what you'll see in addition to this, and I don't see any other cells in this field, if you see a lot of platelets, usually when you see this cell, you see a lot of platelets. Remember the thrombocytosis. But what this is called a micro megakaryocyte. This is a micro megakaryocyte. Okay, I know it's hard. Well, that's a platelet. You know, we've gone over this. This looks like it's round, but it's not quite the size of a red blood cell. Remember, if it's round and almost the size of a red blood cell, then this one's a little bit smaller. I don't think that's probably closer to a lymphocyte up here. But when it's that big, that round, and that dark blue, it's not a blast. This is a micromegakaryocyte. Now this cell is a megakaryocyte. This is in the bone marrow now. This is the nurse cell. This is a megakaryocyte. This is the nucleus of the megakaryocyte. And what happens, development is going outward, and it's endomitosis. This is the whole cell. There is cell division, and what happens is these are platelets that come off of the nucleus, and that's the development. The development is out towards the outer. Here, towards the outer, these platelets are ready to be released, and that's how you get your platelet count. Once that happens, they get released, then they go to the peripheral blood. But this cell here is what you'll see in the bone marrow, and this is the megakaryocyte. This is the mothership. This is the one that creates the platelets that get released into your peripheral blood. All right, it's the nurse cell. I call it the mothership because this is the source of your platelets, and that's the megakaryocyte. If you see karyocyte, that means platelets. Megakaryocyte, we're talking about the mega, the big cell in the bone marrow. So it's megakaryocyte, the big cell in the bone marrow, and it's the biggest cell in the bone marrow. And that is the megakaryocyte, and that's what produces platelets, okay? So treatment of high-risk patients with cardiovascular risk is indicated to control progressive megakaryocyte proliferation. So we want to control the amount of platelets. We don't want too many platelets in your blood. Actually, too much of anything, too much of RBCs, too much of white blood cells, that, CML, and then too many platelets. You can cause problems with clogging up your circulatory system. And I'm going to get into that when I talk about coagulation. You don't want to overcrowd it. Okay, and then now idiopathic myelofibrosis. Idiopathic myelofibrosis. Idiopathic, does anybody know what idiopathic means?
Does it mean like no cause?
Not, that's kind of half true. It's either no cause or unknown cause. Like, for example, idiopathic, what is it? Like if they have an idiopathic fever, it's like what doctors, it's a term that doctors use when they don't know. It's a term that doctors use. I mean, this is what I think. It's terms that doctors use to make it sound technical, but they're basically saying that they don't know what the heck is going on, okay? They don't know what's causing a certain symptom. They'll say idiopathic whatever, idiopathic hemorrhaging, or idiopathic headaches or something. They'll use the term idiopathic. It's an unknown cause. It's not that it's a known cause. Obviously, something's causing it, but they just don't know what it is. There is a cause, but they don't know what's causing it. So it's more like it's an unknown cause. So idiopathic myelofibrosis, fibrosis of the marrow. So it's whenever they do bone marrow aspiration, you always come up with a dry tap. A dry tap is the term that they use for when they go in to do an aspiration. They pull, and they don't get any material. If they get a dry tap, and that's information that tells them that the marrow is fibrotic, a lot of fibrin in there. So this used to be called myelofibrosis with myeloid metaplasia. Okay, so there's myeloid metaplasia. When you get metaplasia, that indicates the production of production of myeloid cells. But then again, it's interfered with the amount of myelofibrosis, or the amount of fibrin in there. So it causes problems in trying to get samples because of the amount of fibrin that's in the bone marrow. So like I said, because of the amount of fibrosis that's happening in the marrow, it's interrupting, or the factory is getting interrupted. So you're not getting normal production of myeloid and erythroid cells. So it's forcing the extramedullary sites to start producing cells. So now you have extramedullary hematopoiesis, and it's in the spleen and the liver. So hopefully you'll see that idiopathic myelofibrosis stimulates or causes the production of blood cells, the myeloid and erythroid cells to be produced in the liver. So that's called now extramedullary. Extramedullary means outside of the medulla of the bone. So it's not in the bone marrow, but you're now having hematopoiesis or blood production outside of the bone marrow. And that's in the spleen and the liver. Leukoerythroblastosis. That's a term that that when I was in training that we had to know and associate with teardrop cells. Okay, so teardrop cells, one of the causes or reasons for having a teardrop cell that I'd mentioned earlier in the earlier lecture was splenectomy, that you have teardrop cells. But the term, I didn't want to tell you, leukoerythroblastosis, I wanted to save it for this lecture, but leukoerythroblastosis is a term that is associated with the presence of teardrop cells in the blood, okay? Leukoerythroblastosis. So it looks like it involves the white blood cells and the red blood cells, and the blastosis meaning it's early stage. So leukoerythroblastosis, associate that term with teardrop cells. Okay, that's a fibrotic bone marrow. You see all the fibrin there. So idiopathic myelofibrosis. Symptoms of idiopathic myelofibrosis that you have fever, you have anorexia, weight loss, night sweats, and bone pain. Okay. 10% of the patients will have serious bleeding. Okay, you would think that with all the platelets, you wouldn't have any bleeding problems, but these are abnormally functioning platelets. They don't function properly, so then you'll have bleeding tendencies. Secondary to thrombocytopenia, you can have a low platelet count, or thrombocytosis, elevated platelet count, or qualitative platelet defects, meaning that you can have platelets that do not function properly. That's what qualitative platelet defect is. They don't function properly. And this all leads to coagulation abnormalities. Again, I'll be talking about that in the next few weeks. Laboratory findings present normocytic normochromic anemia. The red blood cells look normal, normal central pallor, normal size. 25 in half to 90%. 25% will have severe anemia with hemoglobin less than 8 and abundant NRBC. So increase RBC production that to the point where you actually will see nucleated red blood cells in the peripheral blood. You'll also see left shift immature granulocytes, and then the leukoerythroblastosis, you'll see the teardrop cells. So there will be POIC in terms of teardrop cells and left shift and on the white blood cells, and also early or immature red blood cells, and you'll see nucleated red blood cells. Teardrop cells, okay? Teardrop cells, and there's some target cells there. Okay, the treatment for idiopathic myelofibrosis involves the use of cytotoxic agents to control the thrombocytosis, leukocytosis, and splenomegaly. You can use hydroxyurea, and that's use is generally temporary, resulting in anemia, then treated with erythropoietin. So hydroxyurea causes the patient to be anemic, and then you have to treat it subsequently. You have to treat the anemia subsequently with erythropoietin to address the anemia. Okay, one mechanism of action is believed to be based on its reduction of production of deoxyribonucleotides. So the decreased deoxyribonucleotides is hypothesized to be one of the causes of this idiopathic myelofibrosis. Okay, that's it for myeloproliferative disorders. Okay, remember that it's 3 cell lines, increased production of red blood cells, increased platelets. The increased platelets are not functioning normally. The increased red blood cells are treated with therapeutic phlebotomy. You know, they have to donate a unit of blood. That unit of blood, after they donate it, they have to destroy it. Okay, therapeutic phlebotomy bloods, like I said, are not used for the general population for transfusion. They are not to be used for transfusion purposes. They have to be destroyed right away. All right.
Professor Badger, I'm sorry, one question for you. I didn't catch the point that you made about the Philadelphia cells.
Oh, the Philadelphia chromosome? It's
Yes,
negative.
please.
It's negative. So just like anything, it's negative. The only thing about the Philadelphia chromosome that I want you guys to know is that Philadelphia chromosome is only significant for CML, right? You knew that already, right? But I don't know why it was mentioned here, but for chronic myeloproliferative disorders, Philadelphia chromosome is negative. You might as well just say Philadelphia chromosome is negative for having the flu, okay? You're not going to have Philadelphia chromosome, right? The only thing Philadelphia chromosome signifies is CML, chronic myelogenous leukemia. That's the only thing.
Thank you very much.
Welcome. Okay, the next and final topic. This is the final topic in hematology, and it's going to be multiple myeloma. Okay, multiple myeloma is not a good disease to have. It's known as plasma cell myeloma. Now you know what plasma cells, after I told you what the plasma cell was in the image at the beginning of this lecture. Just think about the hard-boiled egg. Just boil a hard-boiled egg tonight, cutting in half, and you'll see, oh my God, plasma cell, okay? Another name for multiple myeloma is Kehler's disease, named after this individual, Otto Kehler. He must have been a scientist. So it's Kehler's disease. Make sure you know these diseases that have names like the Naegeli syndrome, the Kehler's disease, or Schilling's disease, things like that. Those alternate names I want you guys to know. And you'll see that in the mega matching exercise that I'm going to review that I'm going to give you guys, okay? Multiple myeloma is a cancer of plasma cells. You remember what plasma cells are for, correct? What do plasma cells do?
Make antibodies.
Correct. They make antibodies. And what type of lymphocyte do they originate from?
B lymphocytes.
Right. B lymphocytes. Okay. So just like any other cancer, because multiple myeloma is a cancer, it interferes with the production of normal cells in the bone marrow. So it's another situation where the normal cells in the marrow are being displaced. Okay. In multiple myeloma, you collect the abnormal cells in the bones and they cause bone lesions, and they interfere with the production of the normal blood cells. So it infiltrates the bone in the bone marrow and interferes with their normal production of the marrow cells. One thing to note that's characteristic of multiple myeloma, and you need to know this, is the paraprotein. Okay, so each disease or each cancer has unique cells or unique characteristics. Like CML is the Philadelphia chromosome. I guess CLL could be the presence of an artifact like basket cells or smudge cells. Well, multiple myeloma is the paraprotein. And paraprotein is an abnormal antibody that's present. It causes kidney problems and it interferes with the production of normal antibodies, leading to immunodeficiency. So if you don't form antibodies properly, because you need to form antibodies to protect yourself, but if you don't form antibodies properly, then you can be immunodeficient, meaning that you have problems defending yourself against foreign bodies. That's immunodeficiency. Okay, so you have abnormal or inefficient normal antibody production, and it can lead to immunodeficiency. One of the characteristics of multiple myeloma is elevated calcium, elevated serum calcium. And there's an acronym that you need to know, and I'll bring that up later. But the main one is hypercalcemia. High calcium level is often encountered. So multiple myeloma is diagnosed with protein electrophoresis. So when I was a CLS on the bench, I was fortunate enough to do a lot of protein electrophoresis. And that's where you take a serum protein, you inoculate a plate. And I talked about electrophoresis early on in hemoglobinopathies. You do electrophoresis, and what you do is you fractionate the protein into its 5 fractions. And for protein, it's alpha, it's albumin, alpha 1, alpha 2, beta, and then gamma. I'll show that to you later. Also, to diagnose multiple myeloma, you look at the peripheral blood smear, because on the peripheral blood smear for multiple myeloma, you'll see rouleau. Okay, you'll see rouleau formation. Okay, so here you have multiple myeloma, elevated protein, and you'll see rouleau formation. Okay, so elevated protein, what problems could you encounter on the CBC that needs correction? You guys remember?
What was the question again?
Okay, you have elevated protein. So multiple myeloma has elevated protein. And it also has rouleau. You can't do anything about the rouleau, but you have elevated protein. What kind of problems would you see with initial analysis on the CBC?
Elevated MCH2.
Correct. You get elevated MCHC. You spin it down and you won't see anything, correct? But you'll have elevated MCHC. So you'll have an elevated MCHC. What else will you see that could be wrong? Probably the H&H probably doesn't match. So your rule of threes will fail. So how would you correct for that?
Saline replacement.
Right, you do a saline replacement. Get rid of that protein in the plasma. You got excess protein in the plasma causing your MCHC to be super sky high. Okay, so you do a saline replacement and then it comes down. Okay, that's a little review. So peripheral blood smear, you'll see rouleau formation. Bone marrow biopsy, you'll see plasma cells. And X-rays are of commonly involved bones such as the spine, and ribs. It's the second most common hematologic malignancy, and it constitutes 1% of all cancers. Okay, so this is what happens when you fractionate hemoglobin. This is actually a densitometer reading, and these are the fractions of the different proteins when you separate it out from electrophoresis. So when you do electrophoresis, you're going to get spots here, 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 and then a thick spot here. And that's why when you have thick spots, that means the thicker the spot, the higher the peak. The smaller the spot, the smaller the peak. So you have a thick spot here, three small spots, and then at the end, you have a large spot spike here. Okay, so this is electrophoresis. So this is actually a densitometer reading, meaning that it takes a reading of how dense the different fractions are. So for protein, it starts albumin, alpha 1, alpha 2, beta, and then gamma. Gamma is normally like this. It's normally flatter, but it's a little bit more broader. So albumin, alpha 1, alpha 2, beta, and then gamma is usually like this. But in multiple myeloma, you have a spike in the gamma region. So this region here is where you make your immunoglobulins or your antibodies. So you have excess antibody production. Okay, excess antibody production. Antibodies, remember, are globulins or gamma globulins. Okay, so this is called monoclonal gammopathy. Monoclonal gammopathy, and that's because you see this peak here, and this peak is the paraprotein or the M peak. You see a peak like this? That's multiple myeloma. So case study, 59-year-old patient presented with a left facial droop and a known history of multiple myeloma. The CT brain scan was performed looking for a cerebral cause, and the lytic lesion was one of the many in the skull and is consistent with a myeloma deposit. So this is an X-ray, and this is normal. This is what it should look like normally. You got this region here and this region here before you get over here. So what happens is you have this region corresponding, but then you have this lesion here. This lesion corresponds to this, and it's now a lesion. So a lesion. So that's a lesion that's caused by multiple myeloma. And that's what's causing the facial nerve, the drooping. It affects the facial nerve. Okay, plasma cells. If you look closer, you'll see the eccentric nucleus and you'll see the hard vortex, like here, like this one, that one, and this one. Okay, you see, these are plasma cells, plasma cells. These are better looking hard-boiled eggs, plasma cells. Eccentric nucleus with a Golgi, okay? Eccentric nucleus with a Golgi, and these are lymphocytes. These are B lymphocytes. You can see how blue they are. Remember, if you're looking for lymphocytes, look for blue. And more plasma cells. Again, eccentric nucleus, the Golgi, and these are lymphocytes. You can see that this is a problem with the lymphocytes. I don't see any myeloid cells with the exception of, I saw it earlier, of this neutrophil here. And that's probably it. You have NRBCs going on over here, here, and here, and here, nucleated red blood cells. But the majority of these cells are plasma cells. When you see this many plasma cells, which you probably won't, because this is what pathologists will be looking at in the bone marrow, that's multiple myeloma. And on the peripheral blood, which you will see rouleau formation, okay? This is what you'll see in multiple myeloma. You'll see, if you go too far deep in, and I've mentioned this to you if I was teaching lab, if you show me this, I would look at your smear to see how far deep you are, because if you go in way too deep, this is what you'll see. This, and it would not be multiple myeloma. Multiple myeloma. If you see this on the edge of your feathered edge, and you see rouleau early on, meaning that as soon as you see it, as soon as you get on the edge of the feathered edge, and you see rouleau right away, then it's probably multiple myeloma. Okay. The incidence, the disease develops 1 to 4 per 100,000 people every year. And it's more common in men and twice as common in blacks as it is for whites. Conventional treatment for multiple myeloma, the prognosis is 3 to 4 years with treatment and can be extended to 5 to 7 years with advanced treatment. So the prognosis, I mean, it's gonna get you eventually. 3 to 4 years with conventional treatment, and then with advanced treatment, it's 5 to 7 years. All right, signs and symptoms of multiple myeloma. And here's the acronym that you need to know, and it's CRAB. C stands for elevated calcium, R stands for renal failure, A stands for anemia, and B stands for bone lesion, okay? Elevated calcium, renal failure, anemia, and bone lesions. The patient gets bone pain because it involves the spine and the ribs, and it worsens with activity. So this patient is in a lot of pain, and he's pretty miserable. He's going through a lot of pain and very, very uncomfortable. Infections are the most common infections. The most common ones are pneumonia and pyelonephritis, which is white blood cells or infection, kidney infection. Renal failure may develop both acutely and chronically, and it's due to your kidneys are failing due to the amount of calcium that your body is shooting through your kidneys, okay? And it may also be due to tubular damage from the excretion of light chains and called Bence-Jones proteins. Have you ever heard of Bence-Jones protein before? Are you guys are taking urinalysis? And you haven't heard of Bence-Jones protein?
Bence-Jones.
Have you ever heard of Tam-Horsfall protein?
Yeah,
What's Tam-Horsfall protein?
the name is very familiar, but I'm not sure.
I'm glad it's familiar. Tam-Horsfall is the name of the protein in a Highland cast. Okay, light chain. Whenever the doctor is ordering light chains in a urine sample, or these light chains are called Bence-Jones protein. These light chains are the proteins that make up the antibodies. So it all ties in. Light chains are needed to make antibodies. Antibodies are made by plasma cells, and plasma cells are made in the B lymphocytes. So the peak in the protein fractionation we're interested in is the gamma region. Remember, gamma immunoglobulin. Remember your different immunoglobulin classes, right? I'm sure you study those: IgA, IgE, IgG, etc. Right? Okay, so those are the immunoglobulins. Those immunoglobulins will all end up in the gamma region of the protein electrophoresis. Okay, and for multiple myeloma, you're excreting light chains or Benz-Jones protein. Benz-Jones protein are light chains that make up your antibodies. So because you have antibody overproduction, you'll be positive for Benz-Jones protein. So Benz-Jones protein, remember, equals light chains. All right. Benz-Jones protein equals light chains. All right. Anemia found in myeloma is usually monochromic normocytic, normal central pallor and normal size. And multiple myeloma also results from the placement, as any cancer does, replacement of normal bone marrow, and by the infiltrating tumor cells and the inhibition of the normal red blood cell production. So that's usually what cancer does when it infiltrates the bone marrow, not only multiple myeloma, but as I mentioned in earlier, the leukemias or cancers. You get bone marrow involvement. That's why when a patient is diagnosed with a leukemia, one place to find where the cancer cells are is in the bone marrow. So if a patient is diagnosed with a leukemia or a suspected leukemia, one of the first things that they'll do is to do a bone marrow aspiration. And usually they'll do it on the iliac crest, or they can do it on the sternum. Okay, I was fortunate. Hopefully you guys will be fortunate enough to assist in doing a bone marrow biopsy. So those patients who have bone marrow biopsy done are suspected of having a leukemia. And like I said, because of the infiltration of the cancer cells or the tumor cells in the bone marrow, because it's replacing all the good cells, the best place to find it is in the bone marrow. Okay. The next best place to find it is probably circulating around in your peripheral blood. So you guys will see it on the bench by identifying immature cells. If you see cells, myeloid cells that have a lot more to the left, if you see promyelocytes, for example, or if you see myelocytes and you have an elevated white count, those are signs right there that the patient could have a leukemia. Remember, leukemia is 50,000 or higher, up to 100,000. If you have a CBC 50 to 100,000, that's probably a leukemia. And make sure that you are able to identify the immature myeloid cells on the differential. So just remember on the white blood cells, if it's low, it's a viral disease. If it's slightly elevated, 15 to 20,000, it's probably a bacterial infection. And if it's higher than 50,000, then it's probably leukemia. All right. Neurological disorders, again, you get neurological disorders, and that's probably due to the thickness of the blood. Here you have, and remember, the thickness of the blood, you have a high protein level. It's similar to the polycythemia vera. Remember, polycythemia vera, you have excess red blood cells. Here in multiple myeloma, you don't have erythrocytosis. You have the protein. It's the thickness of the protein that causes you to have the headaches or the symptoms, the retinopathy, visual changes and headaches. And that's because of the hyperviscosity of the blood. So the two lectures, or the two portions of this lecture, the myeloproliferative disorders with the erythrocytosis, is the excess RBCs can cause problems in your blood circulation. The remedy for that is to do a therapeutic phlebotomy. And this one, you'll just have to treat it. I'll go come up with the treatments later. But your blood is viscous because of the elevated protein. You can't do a saline replacement of your blood and put it back. But there's medical treatment for multiple myeloma. B lymphocytes, of course, it's related because you got elevated antibody production, elevated light chains, elevated plasma cells. So elevated plasma cells, B lymphocytes, okay, start in the bone marrow and move to the lymph nodes. So you're having overproduction of your B lymphocytes. As they progress, they mature and display different proteins on the cell surface. And when they are activated to secrete antibodies, they're known as plasma cells. And that's by definition, that's what B lymphocytes are. So your immune system keeps the proliferation of B lymphocytes and secretion of antibodies under tight control. You don't want to overproliferate or overdo the production of B cells and the secretion of antibodies. Sure, they're good, but you don't want to overdo it. So you have to keep it under tight control. And when the chromosomes that control the production or proliferation of B cells and the secretion of antibodies is interrupted or damaged, then you can run into problems like multiple myeloma. So when the chromosomes and genes are damaged, often through rearrangement, this control is lost, and then you have proliferation of B cells and the secretion of antibodies. The production of cytokines, you remember what cytokines? By the plasma cells. So plasma cells produce cytokines. And the production of cytokines causes much of the localized damage, such as osteoporosis. So when you have excess cytokines, you're going to have bone problems, and it creates a microenvironment in which the malignant cells thrive. Okay, so you have bone problems, and then you have the presence of malignant cells. And that definition there is cytokines. You've seen it before, that these cytokines, they're not cells, they're proteins. It's a single cell signaling protein molecule that is secreted by the glial cells of the nervous system. Glial cells, as you recall, are the nerve cells, and they're the signaling molecules used in the intracellular communication. So they're important in cell communication. Angiogenesis. So angiogenesis is a phenomenon that takes place in multiple myeloma. Remember, your blood is thick, okay? Your blood is thick, and your blood has problems flowing, and it's thick because of the increased protein, okay? So what happens is a phenomenon called angiogenesis. So say, for example, and I'm going to give you an analogy. Say, for example, you have a river going from San Diego to Los Angeles. That river flows smoothly, okay? It flows smoothly from San Diego to Los Angeles. But if something happens that makes that river thick and the flow of water is not as swift as you would like it to be, and it almost slows down to almost stopping, you need to get that water from San Diego to Los Angeles. So what will happen is your source of water will now find a way to get it to Los Angeles by creating perhaps a side stream. Okay, it's going to create a side stream, and then later on, it's going to reconnect to the main water line and make its way back to Los Angeles. That's what happens with multiple myeloma. The flow of blood is so impeded by the thickness of the blood that new blood vessels are going to form. So you actually will create a new blood vessel because of the sluggishness of the flow of blood in a certain area. So actually you'll make new blood vessels. So you will make, that's what's called angiogenesis. You are making new blood vessels. And that's because in response to the thickness of the blood. Okay, you got to get the blood flowing. So it's going to find a way, and it'll make us another new blood vessel and then reconnect to the main blood vessel later on down the line. So that's angiogenesis. The antibodies produced are deposited in various organs. Okay, remember, you have excess antibody production, and these antibodies are now being deposited in various organs, and it causes problems like renal failure or polyneuropathy and various other myeloma associated symptoms. So it's causing problems all over your body. The treatment for multiple myeloma is focused on the disease containment and suppression. And if the disease is completely asymptomatic, then you're fine. Then you may not need treatment. It's like, again, you're going to need you're gonna consider treatment, but then you also have to weigh the quality of life with the treatment. And the types of treatment for multiple myeloma are include biphosphonates, and biphosphonates is routinely administered to prevent fractures. So biphosphonates is to address your bone issues. Erythropoietin is given to treat the anemia. Okay, biphosphonates and erythropoietin are the two main treatment modes. For advanced treatment, then you can do stem cell therapy and gene-based therapy. So typical therapy, the biphosphonates for your bones, erythropoietin for anemia, and stem cell and gene-based therapy for advanced treatment. Okay, and that's multiple myeloma, myeloproliferative disorders. Are there any questions?
What's this gene?
Pardon me?
Oh, I got a question. What's a gene-based therapy?
Yeah, I don't know. It's probably related to stem cell therapy. It's at that level. Gene-based therapy, probably, probably some kind of transplant where you're going to have HLA matching. You know what HLA matching is, right? Human leukocyte antigen. When you give blood to a person, you're going to do ABO, but then more specific matching would be human leukocyte antigen, and that's probably gene-based therapy. Okay. So let me show you first the mega matching exercise that I'm going to give you guys. Okay. I'm going to send this to you, but this is what I want you to do is like here on the column on the left, are a bunch of diseases or disorders like thalassemia and G6PD, Fanconi's anemia. Remember Fanconi's anemia? It's an aplastic anemia. PNH, paroxysmal gold, paroxysmal nocturnal, paroxysmal gold, sickle disease. So these are disorders and diseases listed on the left. This is only one section, okay? Correspondingly to the right is the answer that you need to match it to. Now, it's not going to be like this because the word bank terms or phrases on the right will be mixed, and you're going to need to properly match, okay? This is a perfect match right here, but I'm going to mix this, and you need to unscrabble and properly match the terms on the left with the terms on the right. Okay, like thalassemia is target cell. G6PD, as you recall, reactive oxygen species. You remember that from an earlier lecture. Vitamin B12 deficiency, you get that from not eating meat. So meat is a term that is associated with B12 folate deficiency. Vitamin B12 deficiency. Fanconi's, remember, that's a congenital aplastic anemia. Aplastic anemia, remember I used the phrase, the factory is shut down. That means everything in your bone marrow is shut down. PNH, the HAMS test is used to confirm PNH. And that's that. I could have put acid serum test, but there I'm going to use the HAMS as a HAMS confirmation is the test for PNH. Cold hemagglutinin syndrome is anti-I. Remember, for cold agglutinins, it's anti-I. It's not going to be a direct by your direct definition, but it's going to be a term that's associated with that disease, like PCH is autoimmune hemolytic anemia in children. Remember that? HDN. One characteristic of HDN is an Rh negative mother. Sickle cell disease, typically it's in Black individuals, but Southeast Asians. So if I put Southeast Asians, you can say, what the heck is up with Southeast Asians? and Southeast Asians can get sickle cell disease, and that was in the lecture. Hereditary persistence of hemoglobin F, as you know, is alpha 2, gamma 2. March hemoglobinuria, okay, that's a hemolytic anemia, and that you get that by crushing your RBCs. Multiple myeloma is biphasic. Is that correct? No, I don't think so. I think that Hodgkin's disease is biphasic. Let me check that. Remember, biphasic meaning that 15 to 35 and then greater than 55. Is that Hodgkin's or is that multiple myeloma?
Hodgkin's.
Hodgkin's.
Yeah, that's Hodgkin's. So we'll scratch that. I'll correct this and then I'll send that out to you. But the term biphasic means it's Hodgkin's disease. But the term I use for Hodgkin's disease is the Ringe-Sternberger cell. Remember that? Ringe-Sternberger cell. Sézary syndrome. Okay, a Sézary syndrome is a leukemic form of mycosis fungoides. I know some of your definitions on your homework didn't have that, but it was part of the definition. But what I was looking for was Sézary syndrome is the leukemic form of mycosis fungoides. And mycosis fungoides in the Hodgkin's, non-Hodgkin's lymphoma, mycosis fungoides was a non-Hodgkin's lymphoma. And then CLL is the most common adult leukemia. It's the most common adult leukemia. And then CML, remember, Philadelphia chromosome. I only want you to know that that's significant for CML. Leukemoid reaction, okay, positive LAP score. And this is another one that that I was kind of disappointed in your answers, because which conditions will show a decreased LAP score? And I gave that to you. There's only two conditions that will show a decreased LAP score, and that's CML and PNH, paroxysmal nocturnal. Everything else, whatever I give to you, is going to be positive LAP. It's going to be positive LAP score. There are only two conditions. CML and PNH will have a decreased LAP score. So leukemoid reaction is positive. Acute promyelocytic leukemia, one of the things found in acute promyelocytic leukemia, and it's most likely due to the granules in promyelocytes, and that's DIC. And I gave this to you today for acute monocytic leukemia is gingival hypertrophies. Gingival hypertrophy is due to the bleeding gums is the result of infiltration in the gums of monoblasts and monocytes in the gums. So acute monocytic leukemia and gingival hypertrophy. Infectious mononucleosis is caused by the Epstein-Barr virus. Pilger-Hubbard anomaly, these are mature cells and they're bilobe neutrophils. Guglielmo syndrome by definition is M6. Lead poisoning, you should recall that that's associated with basophilic stippling. Non-Hodgkin's lymphoma, I mentioned this earlier, it's additional information. Non-Hodgkin's is Roundup weed killer, okay? Naegeli type leukemia, another name for it is the M4. The Schilling type leukemia is M5. And Kehler's disease is multiple myeloma. So though this is only one section, this is the disease disorder section. I have another section here, and I'm not going to mix these terms. These terms are only going to be with the disease disorder area, because in the other sections, like here, inclusion bodies, Howell-Jolly bodies are denatured DNA. Heinz bodies is denatured precipitated hemoglobin. Multiple ring forms, that's malaria or plasmodium. Dolly bodies are agglutinated ribosomes. Our rods are conglomeration of granules. Primary non-specific granules is found in promyelocyte. It's the first granules to show up. And then secondary specific is in the myelocyte and on. So it's myelocytic granules is the secondary specific granules. Toxic granulation are enzymes that are used for digestion. Toxic evacuation is evidence of phagocytosis. Polychromasia, if you see polychromasia in the peripheral smear, that means it's a young RBC. It just got released from the bone marrow. So a young RBC is an indicator for polychromasia. Pappenheimer bodies are made out of iron. Basophilic stippling is precipitated ribosomes. Cabot's rings are remnants of microtubules. So that's what these inclusion bodies are made of. So make sure that you memorize these. Again, the column on the right will be mixed up and you'll just have to mix them up. Cells, okay? The shapes of the cells. Target cell is a bell-shaped cell. Schistocyte, the appearance is no central pallor, okay? Reed-Sternberger cell, as earlier. So you can use information from the previous section to help you out, but the Reed-Sternberger cell is Hodgkin's disease. Rouleau formation in the lecture I just gave you is multiple myeloma. Bite cell is G6PD. Stomatocyte, the shape of a stomatocyte is a bowl-shaped cell. Another name for sickle cell is drepanocyte. And ovalocyte are egg-shaped. Spherocytes are seen in hemolytic anemia. Oval macrocyte is a term I use when I talk about B12 deficiency, and that's in a megaloblastic anemia. Macrophage is the next stage after monocyte. Macrophages are monocytic. Hypersegmented neutrophil is a right shift, and a band is a left shift. So these are cells, okay? So you have a cell section. And now a descriptive term. These are like the tricks that I've taught you guys. Like, for example, I use the term garbage trucks. The garbage trucks go around and clean up your blood and pick up all the RBC fragments and junk that needs to be picked up and disposed of. So the garbage trucks are your macrophages. Deviled egg, I told you, are plasma cells. Rafiki, remember Rafiki on Pride Rock, and he's presenting Simba up on Pride Rock? That's I use that term to describe the antigen presenting cell, because the antigen presenting cell is presenting the cell so that the macrophages or the cytotoxic T lymphocyte can swoop down and take that cell. So I use Rafiki in the Lion King as comparison. Stacked coins is a term to describe rouleau formation. Magnets, remember when I talked about fibrin on the peripheral smear. Magnets, fibrin are magnets for all cells. So if you take a clot from a serum tube, that clot is one single clot, and it's just all fibrin. And what it's done was it just collected all the RBCs, platelets, everything, and made it into one giant clot. So the fibrin sterins are magnets for all cells. And that's why you get inaccurate counts when you have a clotted specimen. Ray bands are Pelger-Hewitt cells. I use the term berries to describe basophils. I told you about the acronym CRAB, calcium, renal, anemia, and bone involvement, and that's multiple myeloma. The factory, I describe the factory as the bone marrow. If the factory is shut down, the bone marrow is shut down, just like aplastic anemia. Chloroma. Chloroma is a green tumor collection of cells. And as opposed to sarcoma originates from bone, in bone and muscle. And then TRAP. TRAP is the acronym that stands for tartrate resistant acid phosphatase, and that's a stain to identify hairy cell leukemia. And then I used hand. Hand in Spanish is mono, so that corresponds to M5 or acute monocytic leukemia. So the hand is supposed to help you identify which FAB classification we're talking about. And then I got miscellaneous terms, like for example, zeta potential refers to the SED rate. Anti-D is for hemolytic disease of the newborn. Anti-I is cold agglutinin. Doneth-Landsteiner antibody is paroxysmal cold hemoglobinuria. Paraprotein, which I just told you, is multiple myeloma. Philadelphia chromosome, again, is CML. 8 subtypes. What do 8 subtypes correspond to? And that's the FAB classification. Roundup weed killer, I just told you today, and that's non-Hodgkin's lymphoma. And gingival hypertrophy, I told you today, is M5. And then finally, the acute leukemias. M0 is minimal differentiation, straight definition. M1 is greater than 90% blast. M2 is greater than or equal to 20% blast. M3, remember M3, 3 letters, pro or promyelocyte. M3 is promyelocyte. M4, 4 syllables, myelomono is myelomonocytic leukemia. M5, mono is monocytic. M6 is erythroleukemia or degugliomas. That's not in here, but it's erythroleukemia. And M7 is megakaryoblastic leukemia. And then the L1, L2, and 3 corresponding to small uniform, large varied, and then large varied with vacuoles. So each term on the left is already properly matched to the term on the right. So what you'll get next week is that you'll get a word bank. Each of these word banks are going to be all jumbled up, and you're going to have to properly match them. Okay, this is your reviewer, and it would behoove you to do well on this because it's worth 176 points. So it'd be nice to get 176 out of 176, and that would greatly improve your current grade. Okay, so hopefully you'll do well on this. Okay. So now I'm going to go into your review. So I'm going to turn off my share screen. So hopefully you won't see what I'm looking at. All right.
Before we do the review, I have a question.
Oh, go ahead.
So next week, November 11, Thursday, it's supposed to be a state mandated holiday. According to
Next
Charles,
Thursday? Next
Yeah.
Thursday?
yeah, according to Charles, we don't have school, but I mean, we're meant to have our exam. So was the plan, I guess.
So I thought the holiday was starting on November 22nd. What's the date today?
The-
That's Veterans Day on the 11th.
Yeah,
So today is the 4th, right?
yeah.
And next week is the 11th. Are you saying that 11th and the 12th is going to be a mandated holiday?
Just the 11, according to the school calendar.
Okay. So I'm going to have to talk to Xavier and see what he's going to do. So he's not going to have lab next Thursday of next week.
We're not sure what the school is going to do, if they're going to close the campus altogether or what they're doing, to be honest with you.
Okay, because you're supposed to have your exam 4, which is multiple choice and matching. And then you're supposed to have a quiz. And then on top of that, I was going to give you your mega matching exam.
Right.
When would you like to take that? Okay, so let's see here. So here's the schedule. Are you telling me that this here, November 11 is a holiday?
Veterans Day.
Oh,
Veterans Day.
That's Veterans Day, huh? All right. If I push exam 4 and quiz 18 to the following week, would you guys be okay with taking a quiz tomorrow? No, you can't because, oh yeah, I can do it. A quiz tomorrow on the lecture today on myeloproliferative disorders, or is that too soon? This quiz 18 is on lecture 18, which is myeloproliferative disorders. If I give that to you tomorrow, would that be too soon?
Too soon for me.
Yes. Yes.
Okay. So which means, okay, so which means that I'm gonna push this quiz 18 down here, down to November 18.
Well, can we do it like online or something? Can we work around that? Because we have another exam on the 18th. So if possible, if we can, you know,
Okay, so you
have that
have,
exam sometime next week.
all right. We can do that. We can do that because I've done that. That's what I did in previous classes. The question is, if I give you something in Word, I'd like to get it back on Word, and a couple of you are having trouble with that. I mean, I get Google Docs and there's an issue with converting it to the regular conventional Word. So what happened when I did it last semester and I gave a quiz, what I would do is, okay, at the end of the lecture, okay, here's the quiz. You take the quiz and I proctor it like this, and I can see all you guys, and then you would email it back to me. And every time you would email it back to me, then I would acknowledge receipt. Okay. So after next Wednesday's lecture, I can give you the quiz and the exam. Okay, because next week is going to be the start of coagulation. And I can switch the lectures around because the lectures in coag are relatively short, that I can cut my lecture time and give you more quiz and exam time. So what the way it's gonna work is I'm gonna email it to you, and you're gonna take the quizzes right there, right in front of me. And then when you're done, you're gonna email it back to me and I can see that you received it, and then you'll continue on. And then I'll say, okay, I got your exams, I got your quizzes, then you can go. I'll say, okay, you can go. So you want to do it that way? The other option is to push it one more week, and I kind of don't want to do that.
I like the first choice.
Okay.
The first,
So then your exam, instead of being next Thursday, is going to be next Wednesday after lecture. Okay. And I'll make sure you get your reviewer. Make sure you study your reviewer, and I'll do a review for next week's quiz, next Wednesday's quiz, no longer Thursday. Next Wednesday's quiz, and I'll give you a review for the exam. All right, is that all right?
Perfect.
Okay, you can't see my screen, right?
No.
You guys better be telling me the truth. All right. Okay. For the exam, it's going to include the leukemias, acute leukemia, all the way to today's lecture, the myeloproliferative disorders. And of the leukemias that I talked about, the two different types, right? I didn't talk about monocytic leukemias. Basically, I talked about lymphocytic and then the myelogenous. There are no monocytic leukemias, chronic monocytic leukemias that I'm aware of, but there's acute monocytic leukemia, that's the M5. But for chronic, it's only lymphocytic and myelogenous. Know the most common leukemia in children and the most common leukemia in elderly adults. Know what an oncogene is and what is antagonist to the oncogene. So what acts against the oncogene? So you have an oncogene, and what's the opposite of the oncogene? And you remember what that is?
Tumor suppressor.
Correct. Okay. And then when a cell is programmed to die, you know what that's called. You should know that. What is that called? Begins with an A.
Apoptosis.
Yeah, apoptosis. So we want tumor suppressor genes to work, correct? Because what happens if a tumor, so if you're very familiar with the process, oncogene is bad, it makes a dying cell come back to life and you got the zombies, right? So that's what an oncogene does. And what acts against the oncogene is what you just told me is a tumor suppressor cell. So we want the tumor suppressor cell to be functioning correctly. So what happens if the tumor suppressor cell does not work? Then what do you end up with?
Cancer cell.
Yeah, you get cancer. Okay. Okay, remember that one page, acute versus chronic leukemia. Make sure you know that. Acute leukemia, you got low platelet count, you got anemia and bone marrow failure. And then for chronic, and remember it's insidious onset, and your laboratory findings are a little more subtle. Platelet count could be normal, white blood count can be normal. Make sure you know the white blood counts, and remember that the chronic, like I said, is not as aggressive, but the lab findings are a little bit more subtle. The acute are more aggressive. Make sure you know that. Okay. Now, just because you have an increased number of white blood cells is not necessarily cancer. So there are some terms that I mentioned, like leukemoid reaction. All that is elevated white cell. Hyperplasia is not necessarily bad. All it is your bone marrow decides to make a lot of cells, but it's not necessarily cancerous. But when you use terms like neoplasia, then now you're talking a little bit more cancerous. But hyperplasia, for example, is not necessarily a bad situation. If you have like a dysplasia means you're producing cells that are dysfunctional. There's something wrong with the functioning. So dysplasia could be a type of neoplasia. But just because you have a hyperplasia, then all that is overproduction. Basically, it means overproduction. Okay, so I talked about in today's lecture, myeloproliferative disorders. What are the cell lines involved? Can somebody tell me the cell lines that are involved?
Red
Whites,
blood
reds,
Whites,
platelets.
whites, reds, and platelets. And in all three cases, it's overproduction. And for CML, what is the translocation? The chromosomes translocation? And what is the chromosome that's involved with this translocation? CML, hello?
The Philadelphia chromosome.
Right, and what is the translocation?
9 and 22.
9 and 22, okay. Okay, so remember when I talked about the BCR gene and the competitive inhibition? And I talked about the enzyme that's involved with the phosphorylation. It gets the phosphate from ATP, and it's the ATP that binds to the cancer cell and that causes the proliferation. And what prevents the proliferation of the cancer cell is the imatinib, which is the medicine, and it binds to the site where the cancer cell will bind to. But that one step where it involves the phosphorylation of the cancer cell requires a certain enzyme. And if the amino acid is tyrosine, what is the enzyme? It would be tyrosine what? You remember?
Kinase.
Right, kinase, tyrosine kinase. So you can have other kinases, other amino acid kinases, but for CML, it uses tyrosine kinase to facilitate, and it facilitates, like I said, the replacement or the transfer of the phosphate group from ATP to the cancer cell, and then you end up with ADP. Okay, so the enzyme that facilitates that is tyrosine kinase. Okay, remember I told you that in CML, like for example, when you did your normal values, and I know that for some of you, memorizing those normal values was pretty painful. And don't worry, I'm not going to ask you normal values again. So one of the normal values for basophil is really low. It's almost nothing. I think it's 0 to 1, correct? But the number of basophils, if it's increased, it can be increased. And if you see increased basophils, what does that indicate?
Basophilic leukemia. No.
Yeah, technically, that's like if it's like 80 or 90%, but we're not going to see that. We're not going to see those outrageous amounts. But if you see increase, how about a little bit lower but above the normal value? Put it that way, like, because you never see it outside of 0 to 1, 0 to 2. Probably 0 to 2 is probably rare.
Would that be like inflammation or chronic inflammation?
Well, you would see it. I was thinking about a leukemia. Which one am I thinking about?
Basophilia.
That's, yeah, it's CML. So in CML, I didn't go over the chemistries or lab findings, but for CML, you have increased basophils. Okay, and I'm not talking about basophilic leukemia. That's certainly a possibility, basophilic leukemia. But if you see increased basophils, but not horrendously increased basophils, and then we're talking basophilic leukemia. But if we see an increase in leukemia like 8 or 9 or 10%, though that kind of an increase, which is really, really unusual, we're talking CML. Okay, another finding in CML is increased uric acid. Okay, so on the chemistry end, you would see increased uric acid, but then on the hematology side, on lab findings, you would see increased basophils. Okay, know the different types of phases in CML: the chronic phase, the accelerated. The chronic is the early phase. I mean, is the current safe phase, and then when you get into transformation, you get into the accelerated phase, and then finally you get into the blast phase. Blast phase is not good, but let me see. So the conversion to chronic leukemia to acute leukemia. When you're in the acute leukemia, what phase are you in? So you start off with CML, and then all of a sudden you can actually turn your leukemia can transform into the acute phase. And what phase is the acute phase?
Blast phase.
The blast phase. That would be the blast phase. Blast phase, that means another term to describe the blast phase is called blast crisis. So once you can transform into the acute phase, you don't usually revert back. Once you're in blast phase, then that's actually terminal. Okay. Okay, so know the cutoff. When I've mentioned one of the lab findings in CML is if you have a white count, a certain number. What is that number when it's elevated to a certain point that you would probably think CML? Throw some numbers out there.
50K.
Probably, but a little bit low. What else?
100K.
Yeah, 100K. 100K is a good number. If you see a white count of 100K, you might want to panic a little. Okay, I already told you about LAP scores. What two conditions is the LAP score negative?
CML and PNH.
CML and PNH. All right. What is it elevated in? Everything, just say everything else. All right. Because if I give you anything other than CML and PNH, then its LAP score is increased. Just know that LAP score is decreased in CML and PNH. And know what is the only proven cure for CML. I'll let you guys look that one up. You know what indolent means, right? Indolent is indolent as opposed to what? Indolent is a term that is used as opposed to another term. What does indolent mean?
Dormant.
When describing leukemia, what was that you said?
Dormant.
Yeah, dormant or non-aggressive. Okay, when it's indolent, you really don't have much to worry about. It's kind of like dormant, or it's not doing much, as opposed to a leukemia that's aggressive, and that's where you get really sick. And remember one thing about the aggressive leukemias. Does it have? If you identify the leukemia as an aggressive leukemia, what does that mean? What can you tell me about your survival?
It's slim.
No, not necessarily. Remember, if you find it and it's an aggressive leukemia, once you find it and you treat it, then that helps your prognosis.
Oh,
The only time that an aggressive is fatal is that you don't treat it. So if you find it and your doctor treats it right away, so that's one of the things that is, I know it seems like an aggressive leukemia, you're done for, right? But if you have an aggressive leukemia and your doctor finds it and he treats it right away, the chances of survival are very, very good. Okay, so just keep that in mind. Just because you have an aggressive leukemia, you say, hey, doctor, treat it right away. Treat it. And then guess what? Your prognosis will be very, very good. Okay, so the opposite of aggressive is indolent. And you know the difference between sarcoma and scleroma, right? Where does sarcoma originate from? Just look at your mega matching exercise and that'll tell you. And what is a scleroma? It's kind of the same thing, but it has a certain characteristic.
coloration.
Yeah, what color is a scleroma?
I want to say green.
Yeah, and you should say green, okay? So sarcoma originates from muscle and bone. Remember that, okay? Muscle and bone. Okay, so sarcoma originates from muscle and bone, but what originates from epithelial cells?
Carcinoma?
Yeah, that's carcinoma. Carcinoma. Okay, one thing that I notice on when I'm correcting your exams is if I say circle all that apply, don't just select one, okay? Don't just select one. Some of you, if I say circle, I mean, if I do the multiple choice and there's more than one answer and I only see one choice, and I'll look to see if I wrote circle all to apply, and I do. So if you see circle to apply, circle all that apply, make sure you circle something else that is a pretty educated guess. Hodgkin's lymphoma, is it very curable?
Yes.
Yeah. If you had a choice between Hodgkin's lymphoma and multiple myeloma, which one would you rather have?
Hodgkin's.
Hodgkin's. Multiple myeloma, even if you treat it, remember, it can go as long as 5 to 7 years. That's 5 to 7 years with treatment. As opposed to Hodgkin's lymphoma, you can live a long time. And know the staging procedures, be familiar with the staging procedures of Hodgkin's lymphoma and the different types of stages 1 through 4. Okay. Know the symptoms of Hodgkin's lymphoma. What is the causative agent of infectious mononucleosis?
Epstein-Barr
Epstein-Barr
virus.
virus.
Oh, you guys are smart. Okay. As you know, mycosis fungoides is not a fungal infection. Is that correct?
That's correct.
What is it?
Mm,
Remember the 4 letters that describes the non-Hodgkin's lymphoma?
Cutaneous T-cell lymphoma.
Yeah. See, cutaneous T-cell lymphoma. So what does the cutaneous mean?
Skin.
Right. So the non-Hodgkin's lymphoma, and I showed you all those pictures, right, of those patients who had the skin disease, right?
mhm,
You want to see them again to remind you?
Sure.
No, you don't.
Oh, okay.
All right. Know the difference between stable and remission? Know how to treat mycosis fungoides. There's treatment therapies. No, make sure you know all the treatments. Okay. Mycosis fungoides. What is mycosis fungoides? What is, oh no. What is the leukemic phase of mycosis fungoides?
Sézary syndrome.
Right, it's Sézary syndrome. Okay, Sézary syndrome. CLL, remember chronic lymphocytic leukemia? Is it a neoplasm of T lymphocytes, B lymphocytes? It's common in children, or it's involved with alloantibody production? CLL. It's leukemia of what?
B lymphs.
The B lymphocytes? That's correct. Remember that CLL is a leukemia, or it's a neoplasm of B lymphocytes, not the T, and it's not in kids. Remember, CLL is the most common leukemia in older adults. So no kids, and doesn't involve the production of antibodies, alloantibodies. Usually to confirm leukemia, what kind of procedure or test do they use?
Biopsy.
Yeah, it's
Flow
less than,
cytometry.
yeah, it's flow cytometry. I think, yeah, biopsy is a good guess, but a less invasive would be an easier one would be flow cytometry. And then if the flow kind of leads you in the right direction, then they'll even confirm it more by doing a bone marrow biopsy. And know how flow cytometry works. It doesn't use cytokines, and it doesn't use immunophenotyping, okay? But it uses do any of you know what flow cytometry utilizes to examine the surface cell markers on the lymphocytes?
Fluorescent dyes.
Yeah, did I talk about that? That's correct. It's fluorescent tags. Okay, so what's the most common acute leukemia affecting adults? Usually acute leukemia, whenever you see leukemia, you're thinking about a younger population, but there's an acute leukemia that affects adults. So which one is that?
Is it CML?
No, it's an acute leukemia. So you got
AML.
one out of two chances.
AML.
No, that's the one that's wrong. What's the other?
Oh,
What's the other one?
Acute lymphocytic.
No,
Leukemia?
that's what ALL
Oh.
is. What's the other one? If it's not ALL, what is it?
AML.
Yeah, AML. Okay, so it's AML is the most common acute leukemia affecting adults. Because you would think that acute leukemia affects the younger population, but the most common acute leukemia affecting adults is AML. And with this AML, is it in adults? Is it fatal? Can
No.
it be fatal? No, when what?
when caught early.
When caught early and treated, but what if it's untreated?
It could progress and you could die.
You can die. So the key is to make sure you catch it and you treat it, because if you leave it untreated, then you can die. I talked about mast cell leukemia. Talked about mast cell leukemia, and that can transform. And usually when you transform something, that usually when transformation takes place, you're going from what type of leukemia to another type of leukemia. What are you going? What are you transforming from and to?
Chronic to acute.
Right. You usually when you do a transformation, you go from chronic to acute. And I use the term in the mast cell leukemia. There's a term. So you have leukemic versus aleukemic, right? There's a threshold that if it's above or less than a certain level, then you call it aleukemic. And if it's above that certain level, then it's leukemic. Do you know what that level is?
10%.
It's 10%. So if it's less than, then it's called what?
Leukemic.
Aleukemic. Okay. Know the complications of acute eosinophilic leukemia? You get all those eosinophils in your blood and it causes problems. Okay. Okay, I use the term today, human embryonic stem cell differentiation. What is the term that is associated to that? Remember the term that begins with a P?
Pluripotency.
Yeah, pluripotency. All right. Polycythemia. Primary, what cell lines does that involve in primary? Primary polycythemia.
Reds, platelets, and white.
Right. And then secondary polycythemia, what cell line is involved?
Only red.
Only reds. Okay. Okay, in your notes, look up polycythemia vera to see the characteristics of polycythemia vera. So I'm going to leave that one for you guys. If you have any trouble with that, email me and I'll enlighten you. And remember, with the idiopathic myelofibrosis, you have a fibrotic bone marrow, correct? And because you have a fibrotic bone marrow, what how does your body respond to that? In terms of cell production?
Produces more RBCs.
Say that one more time.
Produces more RBCs.
It does. Well, it produces more blood cells, but where?
Outside of the bone marrow.
And what is that term called?
Extramedullary.
Correct. Extramedullary. In multiple myeloma, you saw that peak on the electrophoretrogram. That peak is characteristic of multiple myeloma. What is that called?
The
That
peak?
peak.
Mm,
What is the name of that peak?
Are you referring to the electrophoresis pattern, like the gamma
Correct.
globulins?
Yeah, correct. What causes that peak?
The production of the antibodies?
Yeah, there's a one-word term.
One word.
Begins with a P.
Vera protein.
Yes, that's the paraprotein. All right, you know the acronym, right, for multiple myeloma,
Crab?
right? And it stands for what? Increase.
calcium.
Yeah, and what else?
Renal failure.
Okay, and what else?
anemia,
Okay,
Bone
what else?
lesions.
And bone involvement. Can't believe you guys don't know Tam Horsfall protein, but Bence-Jones protein is the protein is light chains that make up antibodies. Antibodies are made in the B cells, and B cells make up your antibodies, and that's what's in the gamma or the gamma region of the electrophoresis gram. So Tam Horsfall and Bence-Jones protein. See, that's where I learned my terms like Bence-Jones protein and Tam Horsfall was in urinalysis. So that's interesting. So what type of individuals get multiple myeloma? What demographic? What type of individuals get multiple myeloma?
Is it like elderly and blacks?
Not some, yeah, okay. Yeah, of I should have probably said ethnicity, but it is blacks. And they are elderly because I think it's above 55. But then again, I shouldn't say greater than 55 is elderly. Greater than 55, I think those people have still a lot of youth in them. Okay, and you know crab, okay. And you know what type of cell is a plasma cell? Plasma cell is what type of cell?
Lymphocyte?
What type of lymphocyte? Yeah, it is a lymphocyte. What type? What type of lymphocyte?
B lymphocyte.
Yes, B lymphocyte. I did mention a very, very bad type of lymphoma. Can you remember a type of lymphoma that's aggressive and it's not a good lymphoma to have? Remember that?
Is it Burkitt's lymphoma?
Yeah, Burkitt's lymphoma. Okay, thanks for answering that. Okay, so just because I say that you have an aggressive lymphoma, does that mean you're basically written off and you're going to be dying soon?
No.
No, because the fact that you caught this aggressive lymphoma means that you're going to treat it and your prognosis is good. So just remember that. Just because it's aggressive, the only time it becomes bad is if you leave it untreated. Okay. And you know the name of the cell that is unique for Hodgkin's lymphoma?
Reed-Steinberg.
Green-Steinberg cell. Okay, and I said, remember, know all the stages of Hodgkin's lymphoma? right? The difference between 1, 2, 3, and 4. And remember the biphasic. Remember, biphasic is not multiple myeloma. I'm going to take that out on your mega match. But what are the two age groups in the biphasic phases of Hodgkin's lymphoma?
15 to 35
Yeah,
and 50, 52.
52.
No,
Oh.
50, 50 and up. I can't remember the exact number.
55.
55.
Okay. Know all the risk factors for Hodgkin's lymphoma. It was interesting to see that human growth hormone was use of human growth hormone was a risk factor because people use HGH for a lot of to help for health reasons, but it can be a risk factor for Hodgkin's lymphoma. So make sure you know all the risk factors for Hodgkin's lymphoma. And you should know this one. What's the most common CTCL?
Jeez.
What
Mycosis fungoides.
right, that's correct. And it's a fungal infection, right?
No.
That's correct. So probably if you're imagining that one picture with that, I think it was a lady, she had that huge lump on her throat. Okay, what does that indicate? That indicates what? Involvement under the skin. So if it involves areas underneath the skin, then chances are what has developed. And then you get cells that now circulate throughout your body. Chances are what has developed.
Tumor?
Yeah, it probably becomes a tumor, but what kind of syndrome have you probably now developed? So remember, mycosis fungoides is a CTCL, so it starts off as cutaneous, but then later on, when it progresses to areas underneath your skin, and now the cells of the cancer can become systemic or leukemic, what do you have? What is that syndrome called?
Caesarea.
Yeah, that's the Caesarea. So when you saw that picture of the lady with the lump on her throat, well, that indicates that areas underneath the cutaneous portion of her skin are now being involved, and now it's progressing to the leukemic phase, which is probably Caesarea syndrome. And how do you confirm mycosis fungoides? And who usually gets it? Mycosis.
Biopsy by the pathologist. Wait, what do you?
Yeah, what
Were you
that was
asking?
right. Biopsy. Right. So you do a biopsy. So yeah, you do a biopsy because those dermatologists, they'll take a look at it and I say, oh, that's a fungal infection. Let me give you some tenactin or whatever. Right. And then 3 weeks later, he's back, hey, that tenactin didn't work. So what's going on here? So that's what dermatologists will do. But a pathologist will say, okay, so you went to the dermatologist and that didn't help. So the dermatologist is actually going to be the one to do the skin biopsy, and that'll give them a better answer. But who usually gets mycosis fungoides? Men or women? Men or women?
Men.
And
Yeah. Okay. So and at what age? Usually.
Over 50s.
Yeah, 50s. 50s. It seems like 50s is not a good age to be. But they do have a lot of life in them still. Okay, and you know the difference between a patch and a plaque, right?
Hmm.
Patches, flat spots.
A patch is flat,
And then the plaque is slightly raised or wrinkled.
slightly raised or wrinkled. Okay. You know the difference between lymphoma and leukemia, right? Lymphoma affects what?
Lymphocytes,
Lymphocytes? No, what
Like
organ?
lymph nodes.
Yeah, lymph nodes. And leukemia,
Bone marrow.
bone marrow, and well, after the bone marrow, where does it go in your body when it comes out of your bone?
Peripheral blood.
Right, bone marrow and peripheral blood. All right, the most common type of leukemia in older adults is what?
CML.
AML.
Wrong and wrong?
Ah!
CLL.
Yeah, CLL. The most common leukemia in older adults is CLL. CLL. And if I was to choose to have a leukemia and I don't want to choose to have leukemia, it's CLL. Even though it's most common, it's one of those that you can live with for a long time. You can also live with CML for a long time. But I would choose CLL. But I'm not going to choose. And CLL is what type of leukemia again? Is it T or B?
B lymphocytes.
Okay. And they're damaged, of course, right? You know that, right?
Mhm.
B lymphocytes, right?
Yes.
Yes.
Okay. And you know, in CLL, you have altered immunity, right? And when you have altered immunity, that's a problem, because when you have altered immunity with CLL, what does that cause you to have?
Infections.
Well, yeah, that could be, but what type of what happens to your immunity? What is that called? It causes you,
Antibodies.
say that one more time.
Autoantibodies.
Correct. So your altered immunity, normally your immunity is to protect you against, is to produce antibodies to protect you against foreign entities. But what happens if your immunity is now all messed up, it's going to cause you to produce autoantibodies. So that's one thing about CLL, is that it can affect your immune system. So you don't want to mess with your immune system. Your immune system already knows how to protect you. But if somehow, if you alter or affect your immune system, now you're having trouble distinguishing self versus non-self. So then, as a result, you produce autoantibodies. And is it obvious to patients with CLL that you have it?
No.
No. So how do you normally discover it?
Asymptomatic routine doctor's visit.
Yeah. And what is one of the identifying characteristics in the hematology laboratory that CLL is present, other than an elevated white count and you see nothing but lymphocytes on the smear? What is the one identifying?
Smudge?
What was that?
Was it a smudge cell?
Yeah, it's a smudge cell, but it's not diagnostic. I remember there's a nurse said, you reported a smudge cell, so this patient, therefore, this patient has CLL. No, you can't do that, because you can have a normal, if you take my blood and then however you make it, and you make a smudge cell, don't say that I have CLL. Okay, it's just one of the identifying characteristics among many things that you look for in CLL. But it's an artifact that's taken into consideration. And you know about TRAP, right?
Tritiide resistant.
Tartrate resistant,
AP. I don't know the rest.
alkaline?
Phosphate.
No, not,
Oh,
not alkaline, it's acid. And what type of leukemia will it is that stain for? It's tartrate resistant acid phosphatase is the stain. And it's a stain that will help you identify what type of leukemia.
Hairy cell leukemia.
Hairy cell leukemia. That's in the, okay, so you're gonna learn a lot from when you go over that mega matching reviewer. Look at that, because that's gonna give you some information that you might want to what it's gonna do, it's gonna reinforce the information that you've learned. If you have CLL, do you want to treat it right away?
yes.
No, you don't want to treat it. You don't want to jump to treatment right away, because if it's not harming you, then let it be. The only time you want to treat it is later on after you identify it. It's not hurting you. Remember, it's one of those insidious leukemias. So you didn't know you have it. So just because you don't know that you have it doesn't mean you have to treat it right away. Okay, you just wait till the symptoms get worse. So you don't want to treat it right away. Okay, that's one thing about leukemia. And acute myelogenous leukemia, what's another name for it? Acute what?
Acute granulocytic
Acidic
leukemia.
leukemia, right? Most common acute leukemia is what?
In kids or adults?
What?
Most common acute leukemia in which age group?
Oh, no, most common, just the most common acute leukemia in general, no age group.
AML.
AML, I think you all said AML. And if you all said AML, then you're all right. If you said otherwise, then don't volunteer yourself. All right, know the benefits, the characteristics of the FAB classification. What does FAB stand for?
French American,
British.
British.
Okay, make sure you know M0 to M8. What, for example, erythroleukemia is what? M what?
M6.
7.
6.
No. 6.
M6.
M6.
What is acute promyelocytic leukemia?
M3.
M3.
3.
M3. What is acute monocytic leukemia?
M5.
5.
Okay. Acute basophilic leukemia.
M8.
M8.
That's M8. And acute megaloblastic leukemia. Remember, megaloblastic is what cell line?
Platelets.
Platelets. So you got acute megaloblastic leukemia. What is that one?
M7.
M7.
Okay, I think you guys got that one. You guys better ace that question. All right. And you know that the acute lymphocytic leukemias, right? L1, 2, and 3. Make sure you know L1, 2, and 3. And you can get that from the mega matching exercise. I've already defined that for you. So make sure you know L1, 2, and 3. So that is the multiple choice portion. Okay, so that one was pretty big. The multiple choice was 87 questions. Was 87 questions, and you're going to get that next Wednesday. So for the matching, okay. The first section is in matching is make sure you know acute versus chronic. Okay, and then your choices are going to be acute versus chronic. So that's either A or B, A or B. The next section is match the terms, and the terms are like paraprotein, smudge cell, basophilia, Philadelphia chromosome, BCRA, ABL. Remember BCRA, ABL? What leukemia were we talking about? You remember? That's the one with the tyrosine kinase and the phosphorylation. You remember that one model that had BCR, ABL? I just don't want you to be freaked out and say BCR, ABL. What the heck is he talking about? What leukemia was I talking about when I talked about BCR, ABL? You guys don't remember it? The one with the competitive inhibition and imatinib, the medicine imatinib. That one was CML, okay? Make sure you know Reiter cell, essential thrombocytosis, I talked about that today, and polycythemia rubra vera. Then the next section is a whole bunch of diseases and stains like Sézary syndrome, Schilling type, mycosis fungoides, Epstein-Barr virus, and you're going to be matching it with the specific leukemias, okay? So know the characteristics of acute monocytic leukemia. You know, make sure you know the alternate names. Erythral leukemia, the alternate name. Hairy cell leukemia, that one's probably the stain. I talked about Hodgkin's lymphoma, like the Steenberger cell, for example. Multiple myeloma, I talked about that today. And that's, remember the alternate name for multiple myeloma is Kehler's disease. That's also in your mega matching reviewer. Again, look very, very closely to that mega matching reviewer, okay, because it has a lot of these answers. Then the next section, and you guys better not get this wrong, it's LAP elevated or LAP low. So there's only two conditions where LAP is low, and that's PNH and CML. And that's it for the matching. 2, 3, 4 sections on the matching. And then finally, your quiz. And your quiz is going to be on your Hodgkin's, non-Hodgkin's. So we went over a lot of those a while ago, you know, like definition of lymphoma, an aggressive form of aggressive lymphoma, and definition of carcinoma, definition of sarcoma, definition of chloroma, you know, or significance of Reen-Sternberg cell, survival rate for Hodgkin's, the different types of tests that they use for staging. I know the different stages. And symptoms of Hodgkin's lymphoma, and the biphasic, know the age groups, which you know. And I think we covered most of that. All right. Are there any questions? I think you'll do well on the quiz. If you focus on that mega matching, you'll do fine. You'll do fine.
We're gonna get.
I'm gonna send that. I'm gonna be sending that to you. Okay, are there any questions? Here's that one. So a lot of good information here. And again, this is comprehensive for hematology. And so, and there's your M0 to M7 actually, and then L1, 2, and 3. So it doesn't have the basophilic. It has the megakaryoblast right there. All right, so a lot of good information on this mega matching. Make sure you read it, make sure you memorize it, because that column on the right, I'm gonna mix it up and you're gonna have to match it correctly. And I'm gonna take out that biphasic and probably think about something else to put in there. All right, are there any questions? So your quiz and your exams will be next Wednesday after the lecture. Is that okay? All right. If you don't have any more questions, I'll be sending you a bunch of stuff, and I'll see you next Wednesday.
Have a good night.
All right, you too. Have a good week.
Good night.
Bye. Good night.